Go ahead, sir. Thank you.
Bismillah ar-Rahman ar-Rahim. In this presentation, we are going to talk about the open fractures, and mostly every one of us is going to see at a time not only one case, but several cases of open fractures. This is a very common problem that we see in the orthopedic practice. We are going to start by showing, as our professor, Dr. Hani, said, the plan of the road. We start by the definition, followed by the consequences and the microbiological aspects, epidemiology, the classifications of open fracture, and how to assess an open fracture case, what's the initial treatment in ER, and what's the next step, which is the treatment in OR, and if there is additional treatment methods, and we are going to finish by our take-home messages. Basically, the open fracture is a fracture with a break in the skin and underlying soft tissues, which communicates with the fracture hematoma. And some of the professors like to describe it as an injury of the skin and soft tissues, which is associated with a fracture, to raise the issue of the soft tissue injury and its importance. It's not just only a fracture, it's basically soft tissue and skin injury associated with a fracture. This is by some great professors. Basically, we know that the rapid separation of the fracture in general creates a void that results in soft tissue damage. As we see here in this video, it makes a void here, as we see again. This void creates some sort of vacuum or negative pressure that when we have skin tear, it creates a vacuum effect that sucks all adjacent foreign materials. So we are going to find the debris and dirt deposited deeply in the deep tissue intermuscular planes and even in the medullary cavity of the bone. The consequences of open fractures starts, of course, by the contamination, crushing, stripping, and devascularization of soft tissues that leads to providing nutritional support for the bacteria and reduced blood supply, which reduces immunity. And all these three factors increases the rate of infection. In addition, there is direct loss of function from injury to the muscles, tendons, nerves, and vessels. And based on the lecture of our professor, Dr. Hani, bone healing is also endangered in open fractures. What are the factors increasing the risk of infection? In general, the risk factors for infection can be divided into systemic factors and the local factors. The systemic factors includes the presence of shock and other respiratory distress syndrome, comorbidities, elderly, diabetes, smoking, compartment syndromes, and hypovascular states, prolonged stay in the hospital, which is a very important issue in open fractures because of the exposure to nosocomial infection and resistant organisms, in addition, of course, to poor nutrition. So the systemic factors should be taken into consideration when assessing a patient with a polytrauma or an open fracture. Local factors include the degree of contamination and the type of contamination. It's not just only the degree of contamination, because some specific environments are very dangerous, like the farmyards or sewage, and inadequate management, which starts by poor debridement with retention of foreign debris and non-viable tissues. Any hesitation in the debridement is refused totally. Inadequate skeletal stabilization, so a part on the soft tissues and part on the bone element, or the presence of dead space, and late debridement later than 24 hours. Regarding the microbiological aspects, the bacterial invasion, the bacteria adheres to the host cells and starts by secreting a protective shield or biofilm that protects her against even the antibiotics. This is followed by logarithmic bacterial growth until the available nutrients are exhausted. This raises the importance of debridement and irrigation, or the host dies, or the host defenses success, which could be 100% success, so the bacteria will be eradicated, or partial success and the bacteria is suppressed, resulting in chronic osteomyelitis. Thus, irrigation and debridement are the keys of successful management of open fractures. Nosocomial infection, is it important in open fractures? Of course, because only 20% of infections were caused by the same organism initially isolated in the perioperative cultures. These cultures taken in the perioperative time revealed only 20% of the organisms all infections in the open fractures. So only 20% caused by the organisms caused at the field, and the other, or 80 or even 92% of open fractures were caused by bacteria acquired while the patient was in the hospital, nosocomial infection. So you have to cover the wounds quickly and avoid covering and uncovering the wound. What are the common bacteria encountered with open fractures? Mostly we can see the gram-positive, like staph strep, and in the farm wounds, the Clostridia is important, freshwater Pseudomonas and Aeromonas, seawater Aeromonas and Vibrio, and war wounds, the gram-negative is important. Regarding the wound cultures, as we said before, routine wound cultures before the surgical debridement were routinely performed prior to 1980s. However, pre-debridement cultures identified the infecting pathogen in only 20 or 22% of cases. So routine wound cultures before debridement are no longer recommended. So if we are going to make debridement, it's not necessary or important to take cultures. Okay, when we are going to take a culture, and this is important to take a culture in an open fracture, if we treated an open fracture, but with time, the wound is infected. So we have infected wound. So this is an indication for culture, but which is not recommended, which is no longer recommended, is the pre-debridement cultures. Epidemiology, well, the incidence is high, accounting for around 30% for every 100 normal person per year, and the average age is 45 years. It's more in males, 7 to 3 regarding male to female ratio. The fractures of the finger phalanges are the most common type, accounting for nearly half of all open fractures. This is followed by the fracture tibia, and third is the distal radius. Regarding the classification, the Gastello classification and upgraded to Gastello-Anderson classification is the most common used classification, despite the overall inter-observer agreement was around 60%. This is Dr. Roman Gastello. Type 1 Gastello-Anderson open fracture is an open fracture, usually from inside to outside, clean wound, and the wound is less than 1 centimeter in length with a simple fracture pattern. We have to know that we are going to talk about the skin and the bone. It's not just only the skin. Okay, type 2. It's an open fracture with a wound more than 1 centimeter. It's not just 1 to 10 centimeters. This has been changed, okay? The open fracture with a wound greater than 1 centimeter in length, but without extensive soft tissue damage, without flaps, and without avulsions. This is regarding the soft tissue, without extensive soft tissue damage, without flaps, and without avulsions. Regarding the size of the wound, it's just more 1 centimeter. So if we have a wound of 3 or 5 centimeters and we have extensive degloving of the skin, this is not considered type 2. Okay, and type 2 is also associated with simple fracture pattern, not complicated fracture pattern. This will going to be seen in type 3. So type 3, as you see, this is a photocopy from the AO. Type 3, it's not determined by just the size of the wound, but by the quality of the soft tissue injury and the quality of the bone injury. Type 3 is high energy in fractures involving extensive soft tissue damage, or multi-fragmentary fracture, segmental fractures, or bone loss irrespective of the size of the skin wound. So the skin size of the wound, it's not the main issue here, but the bone factor is a factor and the degree of the soft tissue injury is a factor. So extensive bone injuries, so either multifragmentary, segmental, or bone loss, it's considered type 3. Or severe crush injuries or vascular injury requiring repair or severe contamination. So even if we have small size wound and we have severe contamination from farmyard injuries, this is considered basically type 3. Type 3 is subdivided into A, B, and 3. A, we have apicut soft tissues available for coverage of the bone. So this can be reduced and covered by the existing soft tissues. Type 3B requires a flap, as we see here. And type 3C, any grade 3 with major vascular injury requiring repair, as we see here in this angiogram. So the fracture type should not be classified in the ER. This is a mistake. Most reliably, it's done in OR, in the operating room, at the completion of the primary wound care and debridement, irrespective of the size. Occasionally, the size of the wound is small, but there's severe injury down or deep. So the size and nature of the external wound may not reflect the damage to the deeper structures. The physical examination, of course, as we said before, general, we must follow the ATLS, Advanced Trauma Life Support Protocol for assessment. This is considered high energy fractures, and the patient should be treated as a polytrauma. This is followed by local and neurovascular examination. And don't be distracted by the open fracture and look always for any associated injuries. This is a high energy trauma mostly. A soft tissue wound in the proximity of the fracture should be treated as an open fracture until proved otherwise. Don't forget the neurologic and vascular examination. And if the ankle brachial index is less than 0.9, vascular surgery consultation and angiogram is considered. This is an important question. Actually, can I take picture with my cell phone and send it to my senior? It's not just only to have it and publish it in the Facebook. No, it's very important for documentation, and it's very important to avoid multiple examination that reduces contamination, as we explained before. As we see here, these sharp ends of the bone tethered this part of the skin. It bites the skin here. What's the problem of that? The problem if we lift that for a long time, the skin necrosis and soft tissue necrosis will occur in this, and this will complicate further the case. So this must be reduced, and this tethering must be released. Don't wait till the definitive treatment. Here we see here a wound. This is far away from the fracture, as we see here, and this is the shadow of the wound here. But this is actually considered an open fracture because it communicates with the fracture through degloving under the skin from here to here, and this has been discovered in OR after debridement. This is an obvious case of open fracture, distal femoral, supracondylar, intercondylar, comminuted fracture. This is a very distracting injury, but actually this case has an associated dislocation of the hip. This is easily missed, but it should not be missed because we all know that an anteroposterior view of the pelvis is one of the radiographs requested in the polytrauma. So don't be distracted by the open bleeding fractures to miss anything of the protocol to manage a polytrauma patient. Signs of vascular injury, we have, of course, hard signs and we have associated signs. The hard signs, of course, when we have severe bleeding, active bleeding from the wound, this is a very hard sign. And if we have absent or significantly different pulsations compared to the normal side, we have expanding or pulsatile hematoma. Expanding hematoma is very important because sometimes the open fractures has been sent to a small hospital, which referred this patient into a bigger center after suturing the wound for hemostasis. But when you see the patient, you know that there's expanding hematoma. This expanding hematoma is a hard sign of vascular injury, or you feel bruit or thrill. The associated signs, associated numbness or neurologic deficit, the difference in the skin temperature distal to the injury, absence of venous filling, and the absence of pulse oximeter reading or no capillary blanching. What are the goals of treatment of open fractures? Of course, the first goal is to preserve the life of the patient. We are dealing with a polytrauma patient. The second is to preserve the limb. So preserve the life of the patient, not be distracted to the limb and neglect serious life-threatening injury. Excuse me. The third is to prevent infection, and the lastly, to restore function. Stages of treatment, we have the acute phase, which is applied in the pre-hospital state or in the ER and in the operating room. And this includes wound debridement, irrigation, and fracture stabilization. We're going to discuss about this. The second is the reconstructive phase. We have steps of skin and soft tissue reconstruction and more reconstruction if needed. And lastly, of course, the rehabilitation phase. So these are the stages of treatment of open fractures. Initial treatment in emergency room, we said before the importance of the photos. Secondly, remove the gross debris from the wound, but don't remove any bone fragments, and avoid irrigation at the bedside, which could be vigorous or aggressive or under great pressure. It should be done, if needed, with a gentle, normal saline lavage, just only gentle, normal saline lavage. But deeper debridement in the ER, in the emergency room, should be avoided because of the risk of contamination of the deeper tissues with the nosocomial infection. There is little evidence, as we said before, to support the aggressive irrigation or irrigation of antiseptic solution in the emergency department, as this can push debris further into the wound. So avoid aggressive irrigation. After you clean up the wound, after that you place a sterile saline-soaked dressing on the wound to avoid cover and uncover the wound, because repeated uncovering and covering of the wounds increases the rates of infection by 3 to 4 folds. Finally, the limb is immobilized in a well-bedded splint. Tetanus prophylaxis should be administered as soon as possible, and we start by asking about the history of previous tetanus immunization. There's one of two cases. Either the patient or the relatives don't know about this, I'm not sure, or the patient is altered consciousness, or the patient already knows, but he received less than 3 doses. This is the situation. And the other situation is that the patient completed his 3 doses or even took more booster dose. This is followed by the state of the wound. If we have clean minor wound, and the patient didn't complete or unknown history of the previous tetanus immunization, he's going to receive tetanus toxoid. In both cases, there is no need for immunoglobulins with clean minor wounds. Immunoglobulins are not needed in clean minor wounds. The question is that if the patient completed the full doses of immunization and the last dose is about 10 years or more, he's going to take the tetanus toxoid. The next is the all other wounds, the contaminated wounds with dirt, feces, saliva, soil, or puncture wounds, avulsions, crushing objects, animal bites, and burns. The tetanus toxoid is going in all cases, okay, if we have less than 3 doses of immunization. And immunoglobulin is going to be taken also. So if we have less than 3 doses of immunization, we are going to take both the tetanus toxoid and the immunization together. But if he completed the course of vaccination, and we're going to check the last vaccination, is it within 5 or more years? If so, he's going to take tetanus toxoid, and he's not going to take immunoglobulin. This is an important note that the toxoid and immunoglobulin should be given intramuscularly with 2 different syringes in 2 different locations. Okay, systemic antibiotics, of course, it's important, and the timing, it should be immediate or as soon as possible, as we say. Studies showed that increased infection rate when the antibiotics are delayed more than 3 hours from the time of injury. Or even I have a recent study here in 2015 that greater than 66 minutes from trauma to administration of the antibiotics was a predictor of infection. So the early, as soon as possible, administration of the systemic antibiotics is very critical. The choice by the gastelograde, usually grade 1 and 2 needs first generation cephalosporin, clindamycin, or vancomycin can be used if allergies exist. Grade 3, first generation, we add aminoglycoside for gram-negative coverage. If we have soil or farm contamination, we are going to add penicillin for clostridial coverage. And if we have freshwater wounds, we use fluoroquinolones or third and fourth generation cephalosporin. Saltwater wounds, we use doxycycline in addition to fluoroquinolones or ceftazidime. And if we are going to do a repeated debridement or second lock, we need a recover for the antibiotics to visits to the OR. For how long we are going to use, we are going to administer these systemic antibiotics? Most current recommendations suggest that antibiotics should be administered for 24 to 48 hours after the last debridement. Okay. Okay, we are going to give the patient these antibiotics for 2 weeks. No, prolongation of antibiotic treatment more than 72 hours didn't seem to offer any protective effect against septic complications of open fractures. But we should take into account that the importance of debridement and irrigation. If we are going to make inadequate debridement or lose, or going to leave dead space, or we have hematoma or something like that, the antibiotics are not going to substitute. So we have different pillars. And then Amida, we have different pillars. Pillar is irrigation debridement. Pillar is antibiotics. This is not a substitute for that, okay? The operating group treatment, we start by the wound irrigation. Here, the amount, it should be copious. There's no solid data, 1 or 2. Although some authors like Engel recommended 3 liters for type 1, 6 liters for type 2, 9 liters for type 3, just only a guide. But you have to wash with copious amounts, with massive amounts, because dilution is the solution to pollution. We are going to use the high or low pressure. The high pressure gives better bone cleaning. However, it causes considerable soft tissue damage and may push bacteria into the deeper tissue planes, as we said, and so slows bone healing. Finally, the low pressure pulsatile lavage was found to be equally effective as the high pressure pulsatile lavage, but with less harmful effects. The choice of the solution, there is no consensus on the type of the irrigants. The predominant preference, however, is normal saline along with low pressure lavage. Antiseptics were found to be toxic to the host defense cells, and the antibiotics, there is no proven benefit, and the detergents may prove bacteria and contaminants. However, the predominant preference, as we said, is saline or ringerose lactate. So the wound irrigation mission is to convert this wound into this one. So you have to irrigate thoroughly. Surgical debridement. When to start the surgical debridement? This is a controversial issue. It starts classically in less than 6 hours. This 6 hours rule was introduced by Frederick in 1898, very long. Okay, but recently this has been changed. Currently, it should be done on urgent basis, not emergency, with earlier administration of antibiotics. So if we administer the antibiotics early, and for a reason or another, the surgery should be delayed into up to 12 or 24 hours, there is no increase in the risk of infection. But this must be based on a reason, because the unnecessary delaying of management of open fractures has not been shown to be appropriate. We are going to, we have an open fracture, 10 EM, and the patient is stable, and we have all the equipment and the facilities, and we have a trained staff, so we have to do, interfere, okay? But the patient, as they say, late night or 1 a.m. patient, and the patient is stable, but we don't have trained staff, okay? So he can wait till the morning. Besides giving him immediate antibiotics and cleaning up the debris and gentle wash. So debridement is recommended once the patient is adequately resuscitated and stable for surgery with a trained staff available. لكل قاعدة شواذ, for every rule there is an exception. The gross contamination, devascularized limb, multiple injured patient, compartment syndromes, all these four require immediate surgical intervention. It's not going to be done on lax basis or urgent basis. No, it's an emergency in these four cases. These steps: use a tourniquet for clear field. Explore the wound. Even in type 1, as we said before, you might have dirt or debris deeper in the tissue planes. Not only the skin. For type 1, it's just only 1 centimeter, and we're going to take only the skin and suture. No, this is a very big mistake. It must be meticulous and systematic debridement, starting from the skin, subcutaneous fat, fascia, muscles down to the bone in layers. Trim the skin margins to the bleeding dermis, and as much as you can, try to preserve a healthy skin adequate for coverage. The coverage is very critical. Excise all foreign materials, necrotic muscles, all bone fragments without soft tissue attachment. So any bone fragment without soft tissue attachment should be removed. Even this results in a defect, the treatment of a bone defect is much easier than treatment of a chronic osteomyelitis associated with non-union. Exposed fat or fascia should be excised. Fasciotomy, as indicated. The presence of an open wound or open fracture does not mean you're not going to have a compartment syndrome. No, compartment syndrome is one of the complications of open fractures. For the muscles, you have to check for the 4 C's of the muscle: viability, color, consistency, contractility, and the capacity to bleed. This is Ahmed Shawqi, Amir Shara. If some of my colleagues like poem, I invite them to read this poem for the surgical debridement. On the edges of the skin, take a piece very thin. The tenser the fascia, the more you should slash her. Of the muscles much more, till you see fresh gore, and bundles contract at the least impact. Hardly any of bone, only bits quite alone. Quite alone, it means that without soft tissues. Maybe you like it, maybe you dislike. Well, I like it. Upon completion of the debridement, we should do adequate lavage, deflate the tourniquet, secure hemostasis, and assess the viability of all retained tissues, and take a second photos for documentation, future reference, and planning of management. After irrigation and debridements, new gowns, gloves, drops, and sterile instruments should be used for fracture fixation. This is the second stage. The fracture fixation, early fracture stabilization, reduces pain, facilitates bed transfers and ambulation, prevents further soft tissue injury, and promotes healing. This can be done using the external fixation, either uniplanar, multiplanar, or circular frames. It can be done on provisional basis or definitive treatment. Intramedullary nail and plate fixation could be used, but with clean wounds and adequate soft tissue coverage. This is an example of provisional external fixation after debridement. We see here the gentamicin. This is a case presented by Robital in Injury 2020. This is converted to the intramedullary nailing and removal of the gentamicin beads. Excuse me. And this is after good consolidation. This is an example of definitive external fixation method. This is a comminuted supracondylar, intercondylar distal femoral fracture. This is after debridement and application of the Lizarov external fixator. And this is with the progression of healing. This is after removal of the frame and sound union. compared to the preoperative CTs. This is one of my cases presented in accepted for publication, not accepted, actually, alhamdulillah, published already in Injury in 2019. For those who are interested, they may refer to this. This is treatment of open intra-articular distal fracture femur by Elizarov fixator. Fixation with plates and screws increases has been associated with increased risk of infection, of course. We have a critical bone defect. The critical bone defect can be treated by the muscular technique or the induced membrane technique. The first stage is to fill the defect with a bone cement, and after 4 to 6 weeks, the bone cement is removed and a graft was applied. The second is the distraction osteogenesis. This is the technique invented by Elizarov in the start using the circular frame, but it can be done also by monoplanar frames. We apply the external fixator here, and we make a corticotomy or just low energy osteotomy, and we make a bone transport to close this gap and reform here by the distraction regenerate. The third option is the vascularized fibular graft that can be associated with skin flap and association. What about the wound closure? The timing studies support the primary closure in many cases due to the advances in the irrigation debridement techniques, improved antibiotic management, better surgical stabilization, and as we said before, most acute infections are hospital-acquired infections. So any delay is going to be a risk for infection. So primary closure is important. Type 1 and type 2 can be safely closed after initial thorough and detailed debridement if there is no concern about ingoing muscle necrosis or contamination. If you have concern, you have to have a second look. But if you don't have any concern for ongoing muscle necrosis or contamination, primary closure is done. Primary wound closure was shown to result in reduced rates of infection and non-union. If soft tissue reconstruction is needed, it should be done within the first 7 days. If we delay this after 7 days, infection rates is increased. It may reach up to 60% after 7 days compared to 27% within the first 7 days. Contraindications of primary closure, this is very important and critical because inadequate debridement is a contraindication for primary closure, gross contamination, farm-related or freshwater emergent injuries, delay in the treatment more than 12 hours, delay in giving antibiotics, and compromised host or tissue viability. The methods of wound closure, it has been said that we have a reconstruction ladder to describe the different steps of wound closure, starting from the easy to the more complicated. This proposes a plan for reconstruction of increasing complexity. However, this has been changed into the revised reconstruction ladder by adding the VAC or the vacuum associated closure and the acute shortening and bone transport. This is the revised reconstruction ladder. And also there's a more modern concept, which is the reconstructive elevator. The elevators that you are going to pick whatever the method. You can bypass all of these and use the VAC, or you can pass all of these and use the distant flap, not sequentially like this. The proximal tibia can be covered with gastrocnemius rotational flap, and the middle third can be covered with soleus rotational flap. The distal third usually requires a free flap, and this is an example of free flap from the contralateral side. This is a form of a local perforator flap. As we see here, we have a grade 3B open fracture. This is after debridement and operative fixation with intramedullary nailing. This is the flap, local perforator flap based on the posterior tibial perforator. And here, this is the flap. This is the open fracture. This is the flap, and this mark is the location of the perforator. This is post-operatively with the flap, without flap necrosis, and there's skin grafting on the donor site. This is a paper presented in 19 in 2019. Another example is the external tissue expander that's used in this case to convert it from grade 3B into grade 3A, like this. This is the device, and these are like skin anchors, okay, and gradually closed after placement. Is there any adjunctive methods? Adjunctive methods, I mean additional treatment methods other than the pillars of antibiotics, the pillars of irrigation, the pillars of debridement, and the pillars of fracture stabilization. We have the local antibiotic therapy, we have the bone morphogenic proteins, we have the coating of the implants, and the vacuum-assisted closure therapy. Local antibiotic therapy starts by, of course, by the polymethyl methacrylate antibiotic beads. They give very high levels of antibiotics locally, and they can be used for management of dead space, like these examples. However, on the other hand, it requires removal. It's not absorbable. It's limited only to heat-stable antibiotics. Increased drainage from the wound has been described. Furthermore, the total antibiotic elution from the PMMA beads is low, since elution is a surface effect. What's elution? Elution is the release of the antibiotic from these beads. It's just only released from the surface, not from the inside of the pellets or the beads. To overcome these complications, biodegradable antibiotic carriers has been invented, like collagen fleeces or collagen sponges loaded with gentamicin, can be cut like this and put in the wound. Again, I want to remind you that these are adjunctive treatment methods. These are not substitutes for lax debridement or haphazard debridement or delay of the antibiotics, okay? This is an additional treatment, not replacement treatment. The second of the biodegradable antibiotic carriers is the calcium sulfate-based antibiotic carriers, like Simulan with antibiotics. We have here, this is already available. We have vancomycin added, gentamicin added, and topramycin added. A mix like that. And when the paste is applied, we wait until it dries, and then we release it like that. We have small pellets to be put in the wound. Local application of vancomycin powder has been associated with promising results, just powder without any carrier. In the previous cases, we used sponge carrier. No, there is no carrier here, just only the powder. Some used 1 gram, some used 2 grams. Local injection of aqueous aminoglycosides. Lowing et al. Injected 80 milligram of aminoglycosides diluted in 40 milliliter of normal saline. And it was injected by the needle down to the bone after completing the debridement and fracture fixation and the wound closure. Bone morphogenic proteins has been discussed by our professor, Dr. Hani, and actually I found clinical trials, not only experimental trials, about the use of bone morphogenic protein 2, and this is already available here. As you see here, it has the name infused bone graft, and it's already approved for use. However, there's no much clinical trials. I only reached 2 studies about this and a review study. But 2 clinical studies used this and have promising results and reported lower rate of invasive secondary procedures. We said that bone healing is an important issue in the fracture and open fractures, and when using this, we have lower incidence of bone grafting, fibular osteotomy, nail exchange, reosteosynthesis by blade, and even we have a significant lower infection rate. Coating of the implants. Now we have available Expert Tibial Nail Protect, which has a coat of gentamicin loaded polymer. For you, if you want to refer to the used studies, reported studies, sorry, these are the 2 papers regarding this. The vacuum assisted closure therapy is very important, and applied for many cases. We have several clinical benefits, including the maintenance of moist and protected environment, removal of excess interstitial fluid from the wound periphery, increased local vascularity, decreased bacterial colonization, quantification and qualification of the wound drainage, increased rate of granulation tissue formation, increased rate of soft tissue contraction, and increased rate of epithelialization. The precautions include take care that when applying this to acute bleeding or patients on anticoagulants or difficult wound hemostasis, ensure that all vessels are adequately protected with overlying fascia, tissue, and other protective barriers. Greater care should be taken with respect to the weakened or irradiated or sutured blood vessels. Contraindications included malignancy, necrotic tissues, and untreated osteomyelitis. It's not a substitute for debridement, fistulas to organs or body cavities, and don't place the vac dressing over exposed arteries or veins. Limb salvage, this is the last issue. I think this is the limb salvage versus amputation. Sometimes the decision comes on the edge. Are we going to save the limb or going to save the life of the patient? Many scores have been described, like the mangled extremity severity score, as you see here, and this is the reference if you want to refer to. It's an attempt to help the decision between primary amputation and limb salvage. If you have a score of 7 or higher, this should be predictive of amputation. Finally, the take-home messages. Its emergency treatment should be consist of as soon as possible systemic antibiotics, debridement by a senior surgeon, and irrigation with copious amounts of saline. The wound closure should be achieved whenever possible, and if you have soft tissue construction, it should be not beyond 7 days. The local antibiotic prophylaxis seems also to be beneficial in different kinds. The most frequent causes of infection in open fracture is incomplete excision of poorly vascularized tissues, incomplete hemostasis and hematoma evacuation, and insufficient drainage of the wound discharges and wound hematoma, devascularization of primarily viable tissues. It was initially viable, but get necrotic later on. Large metallic fixation implants under poorly vascularized tissues, and wound closure under tension, and if you fail to recognize the compartment syndrome. If they have there in the United States, a Pentagon, we have a Pentagon also for the open fractures. The most important 5 elements for the open fractures are treat as an emergency, immediate systemic antibiotics, high quality and thorough debridement and redebridement if needed, stabilize the fractures and soft tissues, and yearly wound closure. Thanks for your kind attention. I'm sorry for the delay.
Thank you so much, Professor Abdel Salam, for this very interesting and updated talk about the open fractures. It's a very interesting talk, Professor Abdel Salam. Coming to questions, we have a question from our dear beloved Professor Mohammed Abdel-Aleem. Does the risk factors have same impact on open fractures from inside?
From inside compared to the outside?
Yeah.
Well, it's basics. Basics, I mean that it's important to make debridement. As we said before, if you have a fracture, it makes a void that creates a vacuum. This vacuum sucks the dirt in the nearby environment into the deeper tissues. So if I'm going to make debridement, for example, I'm not going to say that, no, this is just only a puncture from within. I'm going to debride the skin only and take sutures. No, this is not right, because you may find dirt in the medulla of the bone. So you apply the principles, whatever, grade 1, grade 2, grade 3. It's general principles applied to all.
Yeah, you're absolutely right, sir. Another question, does the administration of antibiotics can wait until obtaining cultures and sensitivity? And what about the optimum duration of prophylaxis?
Okay, again, the first half of the question that we are going to wait for the culture, right? This is the first part?
Yeah.
Okay.
Yeah.
Okay.
Do we have to wait for the obtaining the culture and sensitivity?
No. Totally, absolutely not. Okay. Number one, we said that the cultures are misleading. The cultures are no longer recommended. This is recently. Before this was previously a routine, but currently this is not because it's misleading, totally misleading, and no need to do this. Okay, number one. Number two, we said that the antibiotics not should be as soon as possible. The only thing you want to wait for is the skin sensitivity test.
Yeah.
Okay, in order to avoid anaphylaxis. Just
Yeah.
only this is the. If the patient some papers said that you must give the antibiotics even before the admission steps of the patient, the paperwork of the patient. You know that the admission into the hospital takes some paperwork. So no, you are not going to wait for that. Give him directly the antibiotics, of course, after the skin insensitivity. What's the next half of the question?
And what about the optimum duration of prophylaxis?
The optimum duration, as we said before, 24 to 48 hours after the last debridement. Okay, no need to give it more than 72 hours. And if we have repeated visits into, for example, second debridement or third debridement, if needed, you are going to give him a cover of antibiotics again. Because number one, prolonged covering of antibiotics, 1 or 2 weeks or something like this, does not proven to give a benefit. Okay. Number two, this one of the factors that produces resistant strains. Okay, some of my colleagues is going to ask me, but this is not the current practice here. We have here a dirty environment. We have here a situation different than there in the United States or Europe. No, the principles are the principles. The basics are, number one is adequate and thorough debridement. You are going to debulk this, okay? And you are going to make closure on steps, okay? This is the management. But sometimes you are going, I did this open fracture debridement in 30 minutes. I'm happy that I make fast surgery. No, this is not right. Debridement is very critical.
We have lots of questions, Professor Abdel Salam, because it's a very important topic. Another question from Dr. Adnan Al-Maflah from Yemen. Dr. Adnan, our dear friend, how much bone gap defect can use distraction osteogenesis in treatment? I think this question has been asked in many lectures, and I think we have answered it. Can you please answer it, Professor Abdel Salam?
Okay, we are going to define the bone defects into two types of defects. Critical bone defects, it means that I cannot close the gap acutely, okay? And the non-critical, okay, this is, there's some debate about this, okay? Some people used it on average of 3 centimeters. I can make shortening up to 3 centimeters. And I have read myself that reached 5 centimeters acute shortening, but this is a very big question around the kinking of the blood vessels. So I'm very doubtful about the acute compression to close a bone defect of 5 centimeters. But 1 centimeter, 2 centimeters, okay, this can be done by acute shortening or filling with a graft. Regarding the bone transport, whatever the distance, so you can do bone transport for 15 centimeters. There is no limit for this.
Another question from Dr. Mohsen Yahya. What's your opinion, sir, in primary open reduction and internal fixation for open fractures?
Again, this is dependent on several factors: the general condition of the patient, the comorbidities, and the status of the wound, the complexity of the fracture, and the adequate soft tissue coverage, okay, and the degree of contamination and the type of contamination. If it's just puncture, as Dr. Muhammad Abdel-Aleem said before, just puncture from within, and I made full debridement and adequate debridement, and the general condition of the patient is quite healthy, and everything is okay. There is no limitation. We are going to do internal fixation. As we said before, the intramedullary nail can be applied on primary basis, and there are reports for that. Regarding the open reduction internal fixation using plates and screws, we have two options. The first option is that traditional open reduction and internal fixation that we use large approaches and the traditional open techniques. This carries a high risk of infection. But the minimally invasive techniques are much better than these because of the preservation of the soft tissues, and I'm not going to open multiple tissue planes to disseminate the infection.
Yeah, we have another question from Dr. Ahmed Rezk. How much to enlarge wound for debridement?
Enlarge it to the extent that allows you to see the deeper planes. Okay, what's the idea of enlarging the skin? I want to see what's inside. So I'm enlarging the wound not by centimeters. There's no percentage to enlarge the wound. I'm enlarging the wound to see deep enough, the deep layers down to the bone. Sometimes you have an extensive injury around the fracture, okay, but outside is just only 2 centimeters. No, you may need to open it whatever 10 or 15 centimeters. This is not the issue. The main issue is adequate debridement.
Yeah, another question from Dr. Adel Karfa. When we have to make a second look?
A second look is planned when you, in the first the stage of debridement, you are not quite sure about the viability of some tissues. You are in doubt about the viability of some tissues, and you are afraid that you are going to extensively excise a lot of muscles or so. So you excise the definitely necrotic muscles until you see the forces, but there's some doubt in a little area or some doubt in some structures. So this is a chance for the second look.
Yeah, we have the last question from Dr. Ahmed Rezk. In open fractures with compartment syndrome, can we fix fractures or do fasciotomy only?
So fracture stabilization is very critical in the management. Okay, we have an open fracture. We have a fracture. Okay, say close the fracture tibia, and this closed fracture tibia has been complicated by compartment syndrome. What you're going to do? Just only fasciotomy and leave it without fixation? No, you have to fix it. Okay, whatever the method of fixation, if you are afraid of infection and you are going to plan for later stages of soft tissue coverage, you are going to apply an external fixator. Or if everything is okay, you are going to apply intramedullary nail and then cover the fasciotomy wound, but whatever the method.
Yeah.
But it must be stabilized.
Thank you so much, my dear friend, Professor Dr. Abdel Salam Abdel-Aleem.